Hi, so I'm going to present what we hope is a practical tool you might like to take away, a traffic light approach to assessing respiratory risk, which we've found helpful developing as a team in a dedicated nutrition clinic with some of these difficult challenges around enteral nutrition. So we're often asked, when is the best time to have a PEG? And the sort of closest answer we get from guidelines is try and get it in early before people's forced vital capacity drops below 50%. So both the key European and American guidelines. Obviously we know there's a vast difference between theory and practice, and a low-risk PEG just isn't always possible or desirable, so a patient may wish to delay if they've got bulbar symptoms, but they're still managing okay, eating and drinking, maintaining their weight, and they want to delay till they need it rather than base a decision purely on respiratory symptoms, or they're not ready, they've recently been diagnosed. Patients who present with respiratory symptoms are already in this high-risk group, and we have to think about the best options for them. And prognosis may not be clear if someone has respiratory symptoms and hasn't developed bulbar symptoms, and may not need a PEG in the future, but should we forge ahead or not, and what recommendations should we make then? So I'm going to look at some of the evidence in our local experience about the best method for enteral nutrition for patients with respiratory compromise, and before introducing the traffic light tool and reviewing our use of it to date. So just in case this isn't such a familiar area to you, a PEG, percutaneous endoscopic gastrostomy, percutaneous meaning through the skin, gastrostomy tube in the stomach, and then endoscopic, the method by which it's inserted. So fine tube through the mouth into the stomach, and using transillumination, a light on the end of that to shine through the stomach, find a safe place for insertion. And versus a rig, so radiologically inserted, using an X-ray primarily to find a safe place for insertion. And a rig has been presented as a safer method for people with respiratory compromise, with the obvious advantage without the endoscopy that patients can have full face nasal NIV even through the procedure and use that more easily to support their breathing. With a rig, there's theoretically no need to lie flat, no or less sedations needed, with local anaesthetic being enough, and a lower complication rate than PEG. But these claims aren't based on controlled studies. They're often studies by radiology departments, and rig outcomes aren't then compared to carrying out a PEG with NIV to support patients' breathing or other specific measures, and perhaps with expert gastroenterologists. And they seem to often have high I was about to say high rates of technical failure. I wonder if someone could sort that out. Okay. Yes, so compared to the ones we see with our experienced gastroenterology team. Okay. So although a PEG isn't possible with full face mask NIV, we can carry them out with nasal NIV. And we've found with our team, they can make sure for a PEG, a patient is sitting sort of semi-upright, at least offload some of the pressure on breathing. Whereas with the equipment we have locally, the radiologists report that actually the patient does have to lie almost flat for a rig. And we think it's debatable about whether a PEG or a rig is okay without sedation. It's really a last resort. And from our specialist nurse accompanying patients to have rigs, it's really still quite painful. They're still having an insertion in the stomach wall. Okay. And possibly it's a pre-selected group, but also finding post-procedure sort of high rates of pain from having a rig. Other issues, patient anxiety around having an endoscopy for a PEG when they already have swallowing problems. But that's usually surmountable with sedation, and they say it was a lot better than they expected. There's the extra logistic with a rig of making sure patients have the contrast agent 48 hours before. Hopefully we can get it to them on time to have that at home. If they need to have it via an NG tube, it extends hospital admission. And way beyond the procedure, easier aftercare with PEG that's so important. Because it's secured with an internal disc, it can't fall out. Whereas a rig held in place by a balloon, that's an extra weekly care task, and it can fall out if it's not replaced quickly. It needs another procedure, and the tube routinely requires replacing every 3 months. So it is quite stressful sometimes for patients and carers, and ward and community staff are less familiar with the tubes as well. So from some of the published studies, a different story of PEG for patients with respiratory compromise, if they're supported with an IV, still having sedation. So Botana et al. With a pilot study of 5 patients, an FVC from 21 to 44%, with no major complications. Gregory et al., 29 out of 33 patients had a PEG successfully. The 4 failures were technical failures rather than anything to do with respiratory compromise. And they all had an FVC below 50% and survival on average over 6 months from the PEG. Sancho et al., again with specific measures, so patients with an FVC of less than 50% or on home NIV, having an IV through the procedure, also using cough assist before and after the procedure to clear secretions. And the 3 patients that didn't have a PEG using those measures, it was found the NIV, there was too much air leakage, so they had it with trachea ventilation and all reasonable survival rates. Chell et al., 25 out of 26 patients had PEGs. 10 of those had an FVC below 50%, so they could compare rates between 2 groups. The survival rates weren't significantly different between the 2 groups, an average of 12 months post-PEG. And interesting, the complications were in the non-respiratory compromised group, and they were other complications which, maybe they're more common as well, such as peritonitis and laryngeal spasm. And then more recently, PEG without non-invasive ventilation for patients with respiratory compromise. Spataro et al., and a group of 76 patients, the majority with an FVC below 50%, did have sedation, and again, no major complications. Adds to the sort of complications of the picture that they found the outcomes weren't affected by respiratory severity as measured by FVC, which we'll come on to. And Safati et al., 2 groups, so 20 patients with an FVC above 30%, 10 with it below 30%. Less sedation was used, only 2 patients in each group had sedation. No major complications, and again, no significant difference in survival rates between the 2 groups, but they found oxygen saturation levels at the time of PEG are correlated with a better outcome. So this seemed to tally with local experience that PEG with support for patients with respiratory compromise might be a good option, but it was key in coming up with a measure to assess respiratory risk, that we didn't just stick, obviously, to FVC, which is convenient but not especially reliable in bulbar patients with orofacial weakness. So we wanted to incorporate more use of daytime arterial blood gases, which can be done sort of there and then in a nutrition clinic, and overnight pulse oximetry, which we can post out to patients and they post back, and then get them set up on NIV, including nasal NIV for the procedure. So just an overview of the tool developed by our respiratory consultants, and 3 different sections which we'll now look at. Okay. So first of all, the respiratory assessment data which we fill in, and if there's any doubt around using FVC, then we'll go on to the other measures. So there's FVC lying and sitting and comparing those, SNP, oxygen saturations, as well as arterial blood gases. And then we have to translate those measures into yes/no answers to go on to classify people as red, amber or green on the traffic light system. So a yes response means there's no risk been picked up on that measure, and a no means there is a certain amount of risk picked up on a measure. So, for example, Can the patient lie flat for 20 minutes? Yes, that's a good indicator of not a risk on that measure. And a no, there is a bit of a risk coming out from that. Okay, so if you have all yes responses, patients classified as green, and the PEG can go ahead on just a routine endoscopy list, obviously taking care to re-evaluate that patient if there's a long delay from referral to insertion of PEG. Certain no responses or risks mean the patient's immediately classified as red, so raised carbon dioxide, they're already on NIV, they can't lie flat. An NIV must then be available sort of for use peri or during the procedure via a nasal mask, and they'll be on the specialist team with knowledge of managing respiratory symptoms during the PEG in that clinic, not on a routine list. Amber is if there's any other no responses, so just a reduced FEC, for example, so they still then need to go on the specialist consultant and teams list, not the routine list, but they don't need NIV to be available at that point. There's a few exceptions to the rule, and in those cases, so particularly sort of dependency on NIV via a full face mask would still consider a rig. Okay, so our use of the traffic light tool to date, I've taken it for a period of 10 months, running until August this year to allow sort of scope to mention survival outcomes. We've had 18 out of 19 patients successfully had a PEG. One, they weren't able to transilluminate and went on to have a rig. Of the successful ones, there were 6 green, 7 amber, and 5 red. They all had sedation to some degree, depending on need and risk. So 1 to 5 milligrams of midazolam. One red patient had the procedure with nasal NIV. And we'll look at the survival outcomes a bit more visually. So 16 out of 18 patients have reached 3 months survival, and 14 of those we're still monitoring over time. As you can see, there's 2 patients that died before 30 days after the procedure. So the amber patient died at 25 days, and it kind of raises that question of, well, how long is enough and worthwhile enough to have a PEG if someone desperately needs one? And they're dying of respiratory symptoms and may well have died at that point anyway, and it's so difficult to make that prediction. And the red patient, again, some of the complexities really brought out. The one that died relatively shortly after going home, but was in that difficult situation of having really no other options in order to live and die at home when unable to swallow. And just to mention, so 4 out of the 5 reds obviously have had good survival outcomes, and a further 2 sort of approaching the 3-month mark that have had PEGs recently, and a further 3 reds declined or their PEG was cancelled because their respiratory symptoms had obviously developed sort of since initial discussions around PEG. Okay. So, as we said then, early PEG isn't always possible, although we try and initiate early discussions. We hope that considering using the traffic light approach is helpful to assess respiratory risk more accurately, use a wider range of measures, and it's helped work collaboratively with our local experts, so gastroenterology and respiratory teams in particular, to manage that risk and have certain precautions in place if they are going for a PEG. And there is sort of an accumulating body of evidence that a PEG may be a safe option for, I think, a greater number of patients than we thought sort of certainly 10 years ago, if those precautions are in place. And that gives us hope of extended survival with a PEG for people with respiratory symptoms, and hopefully increasing choice in the timing of PEG and basing that decision around whether they need and wish to have it, as well as their respiratory symptoms. So, thank you. And if you want a copy, please email either me or Rachel, our specialist nurse.
So has anybody got any questions for Melanie?
you very much. That was very interesting. You mentioned sedation, and you showed us the dose of midazolam used in your patients. What about analgesia? What have you done for analgesia?
So they're sort of standard protocols, having fentanyl as the analgesia. I have got the dose, I can let you know them, can't remember them off the top of my head. And then Buscopan is given, again, a sort of standard protocol in the ward, and further analgesia sort of as required, because it does seem to vary how much discomfort and pain there is post-procedure.
Thank you. It's obviously because the opiate will have an effect on respiratory drive as well as the
so
midazolam. So I wondered if you were just using non-steroidal. No, you're using opiate.
Yes, as far as I know, for those patients, again, with adjusted doses. Don't know if Rachel knows any different, but yeah, okay.
Thank you.
Any other questions? Sure, we're early before morning tea. Yep.
Not so much a question, but how really nice to have this, to begin to have this sorted out. Because if you don't have to have your rig changed every 3 months, I mean, that's a real bonus for the gastroenterologist, presumably. So they should really all come on board with that.
Yeah,
Do you want to say a little bit more about how you, I wouldn't like, perhaps I shouldn't say where exactly I'm from in the UK, where I don't think our relationship is terribly good with our gastroenterologist. So how have you made yours good?
It's probably a bit down to luck, isn't it? And yeah, I don't know there's any great secret to that. But, you know, we've got very good PEG nurses as well that helps build that relationship with the team, and they can regularly attend the nutrition clinics. And, you know, someone I think that's interested in the first place has been key, and it maybe didn't mention, but obviously there is different practice in different UK centres, and that might partly depend on those relationships and interest in developing the expertise in a particular procedure.
And you've also got a fantastic care centre, you know, which is renowned. So I'm sure people want to jump on that bandwagon in the nicest possible way. Thank you very much.
Thank you. Anything else? Any other questions? Yep, on my left.
Hi, thank you for your presentation. I wonder, why do you prefer to choose for a PEG, or why?
Yeah. So as I mentioned, the practical advantages, the fact it can't fall out, unlike a rig, it's held in place very securely. That means it's also easier aftercare, and what we were just talking about. So a rig has to be routinely replaced, changed every 3 months. And if it falls out and isn't replaced quickly, then someone might need a repeat procedure. So those are the key reasons, really. And then, again, it might depend on local experience, but because PEGs are so routine, you know, they're relatively familiar to the people that are training patients and families, and that's going to inspire confidence as well to use them. Thank you.
One more? Last one, down the front. Thank you.
Thank you, that was interesting. I'm interested about, it's slightly going off tack, but after the PEG or the rig is in place. I'm an occupational therapist, but my father also had MND. And having a PEG really quite changed our family construct as eating as a social activity. I just wondered if your team provides any advice or support for people with that. Sorry, is that a really hard question?
Yes.
It's off tack a bit, but it's probably something that, as professionals, sometimes we rely on the medical aspect, and we don't always think of the aftermath of that.
Yeah, I mean, it is something...
Not a criticism, just a reflection.
It's something we sort of try and address, you know, from those early discussions, and of course it's a concern before having one as well. I suppose it's just ongoing support with that. Again, not easy answers, and that's, you know, one of the reasons. I mean, even having it in place, you know, body image impact is why, you know, we don't necessarily want to put it in years ahead, just in case it's needed. But yeah, that's quite a big question.
Thank you.
Yeah.
Okay, well, join with me in thanking Melanie.